Oh, Hilton stay, your beds are soft and cozy. No lumpy couch, no stiff futon, no shower line at crack of dawn. Oh, Hilton stay, a holiday you're saving.
When you want holiday comfort you can count on, it matters where you stay. This season, enjoy spacious, comfortable rooms and friendly service when you book with Hilton instead. Hilton for the stay.
This episode is brought to you by LinkedIn. Psst, healthcare pros, word's out, and it's too good to keep quiet. Look, LinkedIn is revolutionizing job hunting, making it possible to search by specialty, shift preference, and salary. Endless scrolling is out. Whether it's a mental health therapist or dental hygienist, finding the perfect role is faster and easier than ever. Head to linkedin.com/healthcare and start your search today.
Welcome to the Dr. Raj podcast with Dr. Raj Dasgupta, a show all about educating patients, students, and aspiring doctors about better patient care. Dr. Raj is a quadruple board-certified physician and associate professor at the University of Southern California. He was a co-host of the TNT series Chasing the Cure with Ann Curry, as well as a regular on the TV show The Doctors. And now, here's our show.
Hi, and welcome to the Dr. Raj podcast. What is this a podcast of? Well, you know that. It's a podcast of happiness. It's a podcast of wellness. It's a podcast of awesome stories. It's a podcast of learning. And yes, I love dropping medical pearls from time to time. And today, I want to do something practical, something that, you don't realize it, but you probably had it or be worried about sometime. It's going to be about drug reactions. Oh, that just can't be a good thing, So whether you're into healthcare or not, we're going to be talking about it. And you know me, if I don't know something, I want to get an expert involved. So today, yes, I got an actual allergist to come here to talk about these drug reactions. So today's guest is going to be, once again, not only an allergist, but my friend. And not only my friend, one of the contributors, authors for my new book that's going to be coming out about microbiome and immuno. We are talking about Dr. Asal Naderi. And you know the way we do this, bio first. So Dr. Naderi attended UCLA for undergraduate education. Medical school was in St. Louis University. She completed her residency in internal medicine at the University of Irvine. Yay, anteaters. I completed my fellowship her fellowship in allergy and immunology at UC Irvine. She was academic faculty at UC Irvine for 6 years prior to becoming a Trojan here at Keck Hospital of USC. She enjoys all that is allergy and immunology and encompasses a special passion for drug allergies, which is what this talk is about today. Dr. Naderi, thank you for joining me.
Thank you for having me, Dr. Raj. I'm so excited to be here and to be able to be a member of the podcast and to help educate individuals listening. And if anyone has questions, do not hesitate to reach out to me later on, because my job here is to educate and to help.
Oh, you sound so nice already.
You're so sweet.
And you look super nice today. And in fact, this is going to be a great podcast because I'm recording in the room together. So, yeah. All right. So let's do the meet and greet questions first. So, Dr. Naderi, why did you want to have the doctor in front of your name? Why did you want to be a medical doctor?
I wanted to help people. And I think everyone wants to help people. And you can help people with many different fields, not just being a physician. But I was intrigued by science. And with my intriguement, the path took me to becoming a physician.
So we have many choices, after med school, our residency and all these things. What drew you to doing allergy/immunology?
So I actually was, like many, I think, physicians that liked all fields in medicine. So it was actually very, very hard to decide because every rotation I did, I loved it. And then by the end of my third year, I was starting to get really, really nervous because I wanted to be everything. And we all know you can't do that. And I was on my pediatrics rotation, and our chief of pediatrics at that time that day was match day, and she actually matched into allergy. And she was so excited. And she was like jumping up and down. And I was like, why are you jumping up and down? And she's like, I matched into this field called allergy and immunology. So then she told me about it, and it was very intriguing. And I met with the division chief at that time of allergy at St. Louis University. And that started my path to becoming an allergist immunologist.
Well, I'm glad you did, or else we wouldn't
you.
team up for our book writing together and everything. You know, on a side note, so my little girl during the wintertime when we're recording this, she got sick.
Oh, no.
And I got a little RSV. So we had to go to the hospital. And I was just thinking back to when you are, I want to do a little bit of everything. One thing I can't do, I'd make a horrible pediatrician.
I don't think so. I think you'd be great.
You think
it's
so?
hard when it's your own kid, though.
They were putting an IV in my girl. And I'm like tearing up.
Because it's your own child. With your own child. It's just very different.
It is. It is. Okay. So I think this is a good kind of like opening question, you know. What is a drug allergy, and can any medication cause a drug allergy? You know what I mean? Over the counter, prescription. How do you define that?
So we have adverse drug reactions and drug allergies, right? If we're talking about a true drug allergy, we can break it into type 1, type 2, type 3, type 4 that we'll get into. But the basic is the most scary one that everyone really, really always wants to avoid is what we call a type 1 allergy, which is where the body makes IgE, i.e. allergy cells against an entity. And the reactions that one can get with that can be itching, flushing, rash, wheezing, hives, swelling, and the most lethal, scary one, anaphylaxis.
Oh,
right?
the words just sound scary.
And then, yes, to answer your question, anything technically can cause a drug allergy.
So this is a hard question because, you know, I didn't realize how broad the definition could be. And we're talking about subcategories. So, you know, my question was, what are some of the common signs and symptoms if you have a drug allergy?
A true allergy. So a true allergy that you definitively want to avoid a medication for. If you, I would say, develop a rash, hives, any part of your body swells, if your throat is closing, any of those, you definitively want to avoid it. If you start having a fever, although it's not a true drug allergy, anything that causes systemic symptoms, fever, I would say, let's say your skin starts to turn yellow, or anything that just seems out of the ordinary, stop that medication and seek care.
So, you know, I'm going to pull an audible. I didn't have this written down, but so I like how we started off. There's adverse reactions and drug allergy, right? So for my listeners or for someone just out there right now, I can see them in Walgreens. How will they know it's an adverse reaction to a drug versus a drug allergy? Because we're talking, you know, just the public,
absolutely.
you know?
So let's say for individuals who take, I would say, ibuprofen.
Okay.
Ibuprofen would cause reflux in many people, right?
Okay.
That's an adverse drug reaction.
Gotcha.
You know, it's going to cause reflux in a majority of people that take it. And you don't have to stop the medication unless the reflux is very bad for other reasons. But that's an adverse reaction, right? But for instance, let's say you have an ear infection and you take a penicillin agent like amoxicillin, and then an hour later, your lip is swollen. That's a true reaction, and you should obviously don't take any more doses of the medication.
Of course.
And seek care immediately.
And is there a little overlap between adverse reaction and allergy for the layperson? They may not know the difference.
A little bit of overlap.
Okay.
I always say, if you have any questions, stop the medication and ask, right? Because sometimes certain things may initially seem like they're not a very big deal. And then later, looking at the pattern, you're like, oh my God, every time I took this medicine, I didn't think I, was itching as much. And now I'm itching head to toe.
So if someone just took a medication, I love ibuprofen, I think I have some in my bag right now, and they started getting a little rash, you know what I mean? Of course, being a doctor, you're going to ask me, and this, but it gets a little rash. Is that enough to say I should stop the medication right there?
I would stop the medication right then and there until it can be further clarified.
Did everyone hear this, my listeners? This is good tips right here. So I told my listeners that I was getting an allergist in here, so I got a question sent to me, and I want to see how you answer this.
Okay.
All right. So can you get a drug allergy after taking a drug for a while?
You actually can. So we'll break it into two different scenarios for you. So we'll go back to the ear infection and the amoxicillin.
Okay.
So let's say you had an ear infection and you started amoxicillin, and I'm going to then say it got, like, let's say more severe and they prolonged your course. So let's say you initially took it for 2 days. The doctor went back, thought it wasn't strong enough, and they gave you amoxicillin clavulanate, right? So it still has an amoxicillin component.
Sure.
And they want to prolong your course. You finished your 3-day course, you stopped it, you resumed the next course. If you have swelling with the next course, you can get it while being on the medication. So something worth paying attention to.
Okay.
And then earlier, we actually talked about while you're on a medication, certain reactions that are done by our T cells in our body. Our T cells are one of our white blood cell count numbers. They're actually notorious for people initially being on a medication and happening either during the course or stopping the medicine and happening days to weeks later.
Oh, that's scary.
So they're very, I say, smart yet tricky members of our body.
So when you're wearing your doctor outfit, if someone comes to you and we're talking about it looks and smells like an allergic reaction, getting a good history, I say, in allergy, I think in all of medicine, but specific in allergy, the history is the most important component of what we do. Because based upon what the patient tells us, we piece together the time course and the type of reaction they have. And that's interesting because, in the ICU, in the wards, we commonly see rashes, you know what I mean? And I think my instinct is always to look at the drug list, what's right in front of you.
Right.
Maybe the trick is, what did that person get the week before or a few days before?
You can always think of it. So for instance, a benign rash that usually happens in a shorter time period. But those more severe, scary rashes that occur that usually will end up in the ICU, the severe cutaneous adverse drug reactions, we call them scars, and you'll have them. There's no ambiguity, right? It's like these really angry looking rashes. People can have fever, blisters on the skin.
Sure.
For a lot of those, it's actually up to 2 weeks before the reaction can happen.
No, this is kind of opening my eyes and door to wow. So I don't know if there's a one-line answer to this, but, we said, where are some signs and symptoms of drug allergies? What about causes? Is it in our body? Is it our immune system? What causes the general drug allergies for most of these people?
It's our immune system and different parts of our immune system, right?
Okay.
The immune system is very fascinating and intricate, right? So for a person who says, I'm just going to come up with hives because that's one of the most common reactions individuals have to medicines, that's because they have a predisposition to have allergies. They got the genetics. They got exposed. The more we actually see a medication, the more likely our body is to make antibodies against it.
Right.
So more often than not, for most medications, it's actually, fun fact, usually your second course of being on it.
Okay.
Your body has to see it before and recognize it, which is why I was saying with the ear infection case, right? They had amoxicillin, they took a little break and went on amoxicillin with clavulanate, and that's how they had their reaction. So that's usually the time course, unless something looks similar, but that's a talk for another day.
So let's, I'm going down from causes to, of course, diagnosis.
Okay.
So you suspect a drug allergy.
Correct.
And it wants to be confirmed. They're seeing you. How do you diagnose a drug allergy beyond just clinically, I now bless you with a drug allergy,
So usually for drug allergy, we go based on history, right? So we actually, fun fact, we do skin testing to drugs knowing the non-irritating concentrations. So this means concentrations that we know should not evoke a skin response that's been tested on individuals who are not allergic.
Okay.
So we know what the non-irritating, that's how we get the non-irritating concentrations. They're all published. And then we poke your skin, just like you would, just a little bit of the medicine, and then either a metal or plastic little poker. We do a positive control, which is histamine, a negative control, which is saline, which shows us how sensitive the skin is. And then we interpret it within 15 minutes. So we know right then and there. But the whole caveat is you only skin test if you think someone isn't allergic. If I think that, let's say, you tell me you took penicillin and you had anaphylaxis a week ago, I'm not going to skin test you. I already know you're allergic, right? So then we skin test to see loss of allergy, right?
Okay.
And then once we know, we do deeper skin tests that are like TB tests and dermal tests.
Sure.
If those are negative, depending on the medication, Then we give the medication in a graded challenge, which means we give, depending on the individual's reaction, history, time frame, you can give 1%, wait 30 minutes to an hour, 10%, wait 30 minutes to an hour, and then the rest of it and monitor them.
So let's keep it simple. I didn't realize how much science goes behind this. So if someone sees you in the office because they think they have a drug allergy, so assuming it's not going to be something life-threatening, you would do the skin testing?
It depends on the timing, right?
Okay.
So let's say if someone came in and they were like, a week ago, I reacted to this. Obviously, I wouldn't do the skin testing because the pretest chance of them being allergic is pretty high. If someone comes in, for instance, we'll pick penicillin because we know people. Fun fact is that most people don't know. People lose their penicillin allergy with time. We lose it at 10% a year.
Oh, okay. Okay.
So let's say a lot of times I have people that come in and say, I was penicillin allergic as a child. I took this medicine and I had hives. Am I still allergic? Right.
Gotcha. That makes sense. So when you were saying that you do it to see if you're, let's say I don't know if I'm allergic.
Right.
And I want to know if I'm allergic to nuts or aspirin or something. That's the people you want to test. Not the ones where I had a reaction.
I definitively know you had a reaction. Well, I mean, it also depends on the time frame of the reaction. Right?
Okay.
So if someone tells me I had a reaction a month ago, more often than not, they're allergic. The caveat becomes, let's say they took 6 medicines during that time period. And we need to know which one was the agent. Then we may skin test you.
And do a lot of people come to see you in the office because they are worried they may have an allergy to such and such based upon a family history or just they're unsure?
Being uncertain, a lot of times, one of the most common reasons people come in is there were siblings. One of them reacted. Mom or dad doesn't remember which one it was. So they both got the label of whatever drug allergy. And now enough time has gone by that they really want to know, was it me? Was it my sister?
When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite, obey your thirst.
The Who's Down in Who Newville were making their list, but some didn't know Walmart has the best brands for their gifts.
What about toys? Do they have brands kids have been wanting all year?
Yep, Barbie, Tony's, and Lego. Gifts that will make them all cheer.
Do you mean they have all the brands I adore?
They have Nintendo, Nespresso, Apple, and more.
What about...
So the Who answered questions from friends till they were blue. Each one listened and shouted, from Walmart? Who knew? Shop gifts from top brands for everyone on your list in the Walmart app.
You know, if you read my chart, it says I'm allergic to aspirin. And my mom, who's a nurse, love you, Mom, told that. I just tell that to everyone. But I take non-steroidals. And everyone always asks me, why did you put it there? I'm like, I don't know. My mom told me. Would I be your patient?
Definitely would be.
Is it what usually
This is usually what comes in. Yes, absolutely.
Yay. So, I mean, you're talking about skin testing. Are there blood testing that's a little more readily? Because, skin testing is poking and skin and time. I'm a pretty lazy doctor. I love a good blood test.
We actually don't have very good blood tests.
Okay. Is that because, they're available, but they're not accurate? Am I saying it correctly?
We only have it to penicillin. It's
really?
available, not accurate, and we don't have it to any other drug.
So here at wonderful USC, do we do the skin testing here?
We do the skin testing. We have wonderful pharmacists. Shout out to the pharmacists that work with me that get to make my non-irritating concentrations every week. Yay! And they make our non-irritating concentrations. We do skin testing. We do intradermals, and then we challenge patients.
So we had some diagnosis. We had some signs and symptoms. So let's talk about treatment into parts. You know what I mean? Because I divided this. You know what I mean? This whole preparing for this talk, our interview got me really pumped up for allergy immunology. If you have treatment of present allergy symptoms, current allergy symptoms, let's talk about withdrawal of the drug. You know what I mean?
Which is number one. Always stop the medicine if you think you're having an allergic reaction.
Okay, so it's not even a treatment. That's like no brainer.
Just stop it.
Yeah. Okay. Now, what about the role of antihistamines and steroids? You know what I mean?
Depends on your reaction, right?
Okay.
So we'll go back to the individual who took the penicillin agent for the ear infection.
Okay.
If they come in and if you're itching, right, and your only symptom is itching, you stop the medicine and you can take an antihistamine because what do antihistamines do? They stop itching.
Yeah.
So then the treatment there would be an antihistamine.
And can you like feel this over the phone? Like, hey, why don't you take some Benadryl? Let's call it out there. Take some diphenhydramine and call it a day.
Yes.
Okay. So antihistamines, over the counter, a simple way to feel better. And when do you want to start using steroids?
It depends on the reaction, right? So let's say someone had lip swelling.
Mm-hmm.
If someone calls me and they're like, my lip is swollen right now, obviously stop the medication first. Antihistamines may work and they may take longer. So what I do is I prescribe them some steroid.
Okay.
Right? I say take the steroid. Anyone who ever has any swelling should have an EpiPen.
Oh, yeah.
Especially if it's acute, right?
Yep.
And then we prescribe an EpiPen. And steroids work phenomenally for most symptoms, let's say. They do cause reflux, just so everyone knows. We tell everyone to take it with food because it can cause heartburn. You can kind of retain water. Some people, it makes them really poor sleepers. They get insomnia. And I've had a handful of people that have had horrific mood changes. So something just worth paying attention to.
Now, in the acute setting, I mean, correct me if I'm wrong, it takes a while for steroids to kick in, right?
I always tell people if it's your lips, start the steroid.
Okay.
If it's your tongue or you feel it's progressing to your throat, you go to the emergency room.
No questions asked.
Okay. You just go.
Yep. Okay. So this one thing's antihistamines, no harm, no foul. Steroids, no harm, no foul. Granted, there's no warning signs.
Correct.
Airway, tongue.
Right.
Anything. I mean, don't even mess around with that.
Don't even mess around. Go.
Okay. I like that. So those are going to be for treatment for allergy symptoms that are happening right there on the spot, But let's say they're taking allergy causing drugs. You know what I mean? They have to be on the drug.
Okay.
So what about things like a graded challenge? Can you explain that to my listeners? And drug desensitization, which I know I've requested this from you folks before for some of my patients on your favorite penicillins. And I don't get that easy for you
so
guys.
let's talk about fun facts.
Okay.
So we do a challenge when we think you're not allergic.
You're not allergic.
You're not allergic to a medicine.
Oh, okay.
So the goal is to show you're not allergic because we're giving the medicine in little doses, not enough to get the body to tolerate it, just enough to see if you react.
And when would someone want a graded challenge? Would they have to be on a med that's known to have a lot of allergies to it? Or
it just depends. So let's say you had, for the individual who had penicillin as a child.
Why not? Okay.
And you did the skin testing and the skin testing is negative.
Okay.
Fun fact, penicillin is our only validated skin test.
Really?
Which means that with that one being negative, it has a high 90% negative predictive value.
Oh, wow.
It's still not 100%. So to cover my 3%, I do a graded challenge to make sure that the person isn't allergic. 97% chance they're not allergic, but to cover that 3%, I give it to you in office.
So that's where the graded challenge comes again. So you do the skin testing, positive is positive, you're allergic. But if it's negative, you really want to know.
Correct.
You've got to do the graded challenge.
You have to do the graded challenge.
Now, I think I know the answer to this, but I'd rather ask you. We're calling it penicillin.
Right.
We're calling it penicillin. So does this cover all beta-lactam drugs? So does it cover, for my dorky medical students that I love, cephalosporins and carbapenems, or is it strictly just penicillins?
The skin test or the negative predictive value? The skin test I can do with any medication.
Skin test. So let's say I'm going to take Keflex, which is a cephalosporin, but it's part of the beta-lactam penicillin family per se. You skin test me, it's negative for penicillin.
Graded challenge.
That's graded challenge. And what happens if it's negative? You could to take a cephalosporin, any type of beta-lactam.
Well, that's a little bit more complicated than that. So let's say we have different categories that we break cephalosporins into. Most individuals who are cephalosporin allergic, it's not the beta-lactam ring. It's the ARG side chains.
Okay.
And we have tables that we look at based on what someone tells us they're allergic to see what they can take. But hypothetically, let's say someone says as a child, I took Keflex. That's what they thought I was allergic to. Can I take Keflex again? Then we specifically check to that cephalosporin. Or let's say someone wanted them to take something else.
And that's where it starts off with skin testing with Keflex?
Skin testing with Keflex.
How do you skin test for a Keflex? You literally put Keflex in there?
You put non-irritating concentration of
Keflex.
We poke through. If it's negative.
And that's why you gave a shout out to the pharmacists. They're the ones that make this.
They are the ones that make this all possible. It is technically our pharmacists. I would say they do 99.9% of the work. The allergists do 0.1%.
So, you're so nice. So, can you skin test almost anything?
Almost, yeah.
And someone just has to create it.
Correct.
That's the trick.
That's the trick. Fun fact, you can skin test chemo too.
Okay, I want to skin test danirubicin, bleomycin.
Yes.
You could do it.
You could do it.
And they just have to create it. Oh, I love it.
Chemo, just as a fun fact, is a little harder because in hospitals, not everyone can touch chemo. So it has to be a chemo nurse who does it.
Yeah.
I used to do a lot of chemo skin testing and desensitization at UC Irvine.
Yeah.
We had a huge chemo allergic population.
Yeah.
And we did it though.
So this is great. I'm going to be answering my own questions here. So if I want to worry about a specific antibiotic, even if they're grouped in families like beta-lactam, I could ask a specific drug I want to get tested for.
110%.
I want to give some meropenem.
And I want to know.
And I want to know.
Absolutely.
So that's why there's no need to talk about the broader penicillins covering everything. You could test specifically.
Exactly.
Oh, I love that. Okay. So what is the difference between the drug desensitization and graded challenge and broad strokes?
So technically, graded challenge, right, we do when we don't think you're allergic.
Okay.
Desensitization is a process where we get the body to tolerate a medicine when we either perceive you're allergic or definitively know you're allergic.
Okay.
Right?
So they have to have the drug.
So they have,
and there's no other options, I assume.
Yeah, they have to have the drug for whatever reason. There's nothing else we can treat, and we get the body to tolerate it.
Okay.
Desensitization is time consuming. It has to be done in the ICU. One-to-one nursing. Shout out to our ICU. You can do oral desensitizations or IV, and we actually dilute the medicine. Standard is 1 to 1,000 dose, 1 to 100, 1 to 1, and we incrementally go up.
And this is going to be, obviously, you read the case, why are we doing it, what's the purpose behind it, because it's all about to benefit the patient.
Right, absolutely.
And we're slowly building up the dose that they need. So let's say that we're giving Zosyn. I don't know why I just said Zosyn. Piperacillin, tazobactam. And we want to give it 3.375 milligrams Q 6 hours. You would build your way up to that dosing.
So we build up to the final dose.
Yeah.
And the fun fact is that the desensitization only works while the patient is on the medicine. So let's say that individual finishes their course in the hospital.
7 days. They finished
7 days is done. They received it every 6 hours like they were supposed to. Once the medicine stops, they are allergic again.
And we're assuming we'll do a desensitization if they don't have those evil reactions, anaphylaxis, angioedema, any of those things. Then there's no way we're going to desensitize.
No, that's what we desensitize for.
Wow.
That is
so with almost any drug, you could desensitize them and prevent.
You can technically almost desensitize to anything that's IgE mediated, right? The caveat becomes these really, I call them sneaky severe cutaneous adverse reactions. These are the T cells that start reacting.
Yeah.
Right? So let's say we're going to take, sulfa, because everyone knows sulfas are notorious.
Yeah.
So you take a sulfa for something.
Okay.
2 weeks later, you have a fever. You have this horrific violaceous drug rash.
Okay.
You don't really feel good. You go to your doctor's office. They run blood tests on you. You have these allergy cells called eosinophils that are high. You have these other allergy white blood cell called lymphocytes that are high. Your liver tests are through the roof. Then we calculate and we think, you have this really bad drug reaction with eosinophilia and systemic symptoms. For any of those, any end organ damage, so let's say someone took another medication and their liver enzymes shot up. Kidney doesn't work because of a medicine. You have vasculitis.
Sure.
I would say drug-induced lupus, any blistering skin peeling off, it's so red. Those are all contraindications to desensitization.
That makes sense. 1,000%. Now, let me ask you this. Have you ever done a drug descent and it backfired and someone needed to have the epidose?
Yes.
Even though we were very careful and going up there, and that's hence why you're in the ICU.
Yes. You're in the ICU because although the risk of reaction is low, it's not completely unattainable. It depends. So since we're starting, we'll go back. So we're starting at these super low doses, right? So most people aren't reacting at the initial steps. It's the final step when you're giving the higher doses that people start reacting to. I have had people who have gone into anaphylaxis. We've treated them through it. If you go into anaphylaxis, your desensitization is done for that day. What we do is then we go back and you can always add more steps next time.
Okay.
Right? knowing what step they reacted to.
Sure.
And then get them usually to tolerate it.
Whew. I feel like I understand this now. That makes me so happy.
Thanks for listening. This has been a production of Ars Longa Media. Our producers are Madison Linden and Chris Brightigan. Our executive producer is Dr. Patrick Beeman. This podcast is for educational purposes only and not intended for medical advice. Ars Longa, Vita Brevis.